Okay. Jack Iola sent in some questions. He said, at ASH, you were part of an abstract focusing on RVD Lite. Since patients like anything light, can you say more about this regimen, and is there also a maintenance light? Are the treatment results for this regimen being used on high-risk MM patients? So it's really almost a three-part question.
Yeah, so the RVD Lite regimen is basically the combination of RVD, lenalidomide and Velcade and dexamethasone that we use as the standard of care for myeloma patients. And for older patients over the age of 70, or for non-transplant candidates, or for someone who cannot tolerate the twice-a-week regimen, we said, well, can we cut down the dose of Revlimid, cut down the dose of Velcade, but still give that three-drug combination for older patients? And the reason for that is older patients were not being treated aggressive enough because everyone was saying, well, they're 80 or 85 years old, or they're not going to do very well with the aggressive treatment. So we said, well, we don't have to give very high doses and aggressive treatment, but we can still give good treatment options. And this is where we came up with this RVD Lite option. The trial is accruing very well. We're almost done with it. And it basically gives under-the-skin Velcade once a week, Revlimid at a lower dose, and dexamethasone at a lower dose. And that option works very well for patients who are frail, older, who cannot tolerate the regular treatment. I would not give that option for very aggressive or high-risk myeloma because we're cutting down the dose of treatment, which means we may not be taking care of all the bad myeloma cells. So I would be very careful when we choose options. We're choosing them for right patients, and of course the age and everything comes into account, but we're also careful that we don't undertreat, because that's not good either, because you'll develop resistance to therapy and then you develop really bad myeloma afterwards.
Well, thank you. Well, also he asked, what test results seem to be the best indicator to determine the risk to progression, like M-spike, free light chain, plasma cell percent, et cetera?
Yeah. So we look at several things to see if patients have poor risk features for myeloma. And probably the best ones are the cytogenetics and the FISH, which are the chromosomes and the mutations or the translocations that we see in the myeloma cells. We also look at the international staging system, which we just talked about earlier, the ISS stage system, and that's stage 1, 2, and 3, based on something called albumin and beta-2 microglobulin. The light chains and all the other markers usually do not predict too much the prognosis of the patients. They tell us how much tumor cells are secreting protein and how much tumor burden in general you have. But a higher light chain may not be a worse prognosis than a lower light chain.
Okay, thank you. Is a watchful waiting approach still standard protocol for smoldering myeloma or myeloma with no CRAB symptoms? What if there are no CRAB symptoms but a severely compromised immune system?
Yeah, so yes, observation or watch and wait is still the standard of care, although that in most of us is starting to change with all the clinical trials that we're developing now for high-risk smoldering disease. For the low-risk smoldering, we still do the watch and wait or observation. Now, it's a great question. What if I don't have the CRAB criteria, but I have other things? So we're starting to redefine also smoldering disease, and we're redefining what is considered symptomatic myeloma that we would treat. And there was a recent publication that came out from the myeloma working group, basically all of us saying certain patients will need to be treated as active or as real myeloma, even if they don't have the CRAB criteria, especially if their light chain is over 100 as a ratio, if they have lesions inside their bone by the MRI or by a PET CT scan, or if they have other things that indicate that indeed they will develop myeloma very fast. So these are new changes that we've added into the CRAB criteria for myeloma. Now, if you have a really bad immune system, this is still something questionable, and it will probably make the patient into the high-risk smoldering criteria by the Spanish group. So it's complicated, and it needs someone who really knows what's going on with smoldering criteria, and hopefully we will make them much easier to understand instead of having so many of those criteria. And that's why you should go to a myeloma doctor who hopefully can look at the whole picture and decide with you.
Okay, well, thank you. Could you elaborate on the mechanism that some of the most promising new strategies are based on?
As far as
new treatments. Mm-hmm.
Sure.
I guess like CD38, and I think that's what are the mechanisms?
There are multiple new drugs, and each of them, of course, have different mechanisms. If we're talking about the antibodies, the new antibodies, so there are two major antibody classes that are coming out. One of them is called ilotuzumab. That's the one I talked about for the smoldering trial. And that goes and attacks the myeloma cells because all of them carry the same antigen, something called SLAM-F7 or CS1. They also can enhance your immune system by making the NK cells, which are the immune cells, go look for the myeloma cells and kill them. So that's how it works. The nice thing about antibodies is you can think of in lymphoma, we use Rituxan all the time, and that's the standard drug that has made a huge difference in the treatment of lymphoma. And that's because all of the lymphoma cells carry an antigen called CD20, and Rituxan is an anti-CD20 antibody. We did not have that option in myeloma for many years. We were actually very envious of the lymphoma doctors because they have a great drug, a great antibody, and we didn't. So finally, we're getting two types of antibodies. The SLAM-F7 one that I told you, elotuzumab, and there is another one called anti-CD38. So again, an antigen that's present on all of our myeloma cancer cells, and that one, there are two different types of them. One is called SAR and one is called daratumumab, and both of them are in late clinical trial options, and hopefully we will have them FDA approved soon. So those new antibodies are not available yet in the clinic, but they are available in clinical trials right now, and they're giving us very good responses, either alone or with Revlimid or with Velcade or with other proteasome inhibitors and immunomodulators.
Okay, what is the criteria which classifies as MGUS or smoldering patients as being at high risk for progression to multiple myeloma? Or how do you identify which patient is more likely to transform from MGUS to full-blown myeloma?
So we have certain criteria. The major ones were developed by the Mayo Clinic or by the Spanish group. For smoldering myeloma, for example, for you to be called smoldering myeloma, you have to have 10% plasma cells in the bone marrow, or an M spike more than 3 grams, or a light chain ratio that's abnormal. And then when we start looking at what will make the patient high risk to develop myeloma very fast, the Mayo Clinic criteria said, well, if you have all three of those, then you're really high risk, you will develop myeloma in the next 2 years. So if you have an M spike of 3 grams and 10% plasma cells and light chain ratio abnormal, you have a really high chance of developing myeloma in the next 2 years. The Spanish criteria was slightly different. They looked at your other immunoglobulins. So if you have an IgG type and your IgG is high, if your IgA and your IgM are low, then that's not a good sign. And if your plasma cells in your bone marrow are all bad cancer cells, 95% of them, then also that's not bad. That's not good, sorry. Now, the problem is that these are very complicated criteria, so we're trying to change that to make it easier for us to diagnose high-risk smoldering. And there will be new publications coming out saying if you have IgA smoldering, that's bad. If you have bad cytogenetics like 17p deletion or 1q amplification, that's also bad, and so on. So we're adding other things and trying to make sure that we unify it so that the Spanish are not doing one thing and in the U.S. we're doing a different thing. Okay.
Well, that would be a good thing, that there's some commonality. What are the signs and symptoms that an MGUS patient should show for the doctor to decide to start treatment? He's talking MGUS. I know earlier it was organ damage, but that would have indicated full-blown myeloma, which was used as the benchmark to initiate treatment, but it is not considered an effective one. Has there been any changes to that benchmark? But they were talking about MGUS, and I'm confusing it a little bit.
MGUS, by definition, should not have any organ damage, should not have the CRAB criteria, and should not have symptoms. Mm-hmm. So that's why we're not treating them. If someone has a small protein in their blood, but they have symptoms, then they don't have MGUS only. They must have myeloma. However, if you have a tiny protein and someone diagnosed you with MGUS, but you do feel, oh, I'm bleeding easily, or I do have problems, I have symptoms, then they could check you for something called amyloidosis. Or in some cases, we have patients with MGUS, but they also have numbness and tingling and neuropathy. These are rare cases where we still have MGUS, yet they have some other symptoms, and that's important to differentiate from real active or symptomatic myeloma.
Thank you. And what are and you've answered this to a degree, but maybe there's a few more. What are some of the more promising clinical trials that the MGUS patients can or should take part in?
So again, we don't have therapeutic trials for MGUS yet, but we do have one of the trials that I talked about, the precursor clinic that we have, which is just giving samples and understanding genomic questions of evolution. However, for smoldering, we have a lot of clinical trials available. We have the vaccine trial, we have the elotuzumab and lenalidomide trials. Multiple other centers have many other trials, so there are lots of options for patients with smoldering disease.
Okay. One of my questions is on this, where you're trying to make the microenvironment less hospitable. When does that go into trial with humans? Now that we've cured a few mouses or mice.
Yeah. So we're not there yet. We're testing some of those drugs in relapsed myeloma. We have not started to test them in earlier cases. And the reason for that is for you to use a drug in MGUS or smoldering, you have to make sure it's safe, it's effective, it has been tested well before we take it into earlier stages. So we've tested already some of the CXCR4 antibodies in relapsed myeloma. We've taken the SDF1 inhibitor that I talked about in my talk in relapsed myeloma, but we have not started yet taking them into earlier smoldering disease.
Okay, and in the mouse model, is that the same drug then?
Exactly, yes. So we test the same drugs in earlier cases to see how it works, absolutely. The immune checkpoint inhibitors could be also very interesting to test in earlier smoldering disease. So we're designing a lot of trial options that will definitely affect the microenvironment as we talked about.
Yeah, and these can also, I understood, be used when you've relapsed and have gone through a second, remission, shall we say, and then use those drugs that tend to affect the microenvironment to prevent relapse. That also could be coming up, right?
Exactly. The question would be, after someone gets a complete remission, let's say post-transplant or post-induction therapy, is the microenvironment important to predict who will progress and who will not progress? And this is what we're trying to understand also, and trying to use the same drug post-transplant or post-maintenance therapy to achieve a deeper remission in patients who have achieved already a complete remission.
Okay, I know the company that's doing that is very small. Does that prevent them from progressing very quickly because they just don't have the resources?
It depends. If we're talking about the SDF1 drug, you're right, it's a very small company. There are multiple other options that we're looking at with different companies, and some of them are bigger than others, yes. But that's one of the limitations of some of the clinical trials. You're right.
That'd be a great crowdsource initiative, wouldn't it?
Yes. You can add that to the list, absolutely.
Yeah. Okay. Early treatment is considered to be more advantageous than disadvantageous But what about the adverse effects of all these drugs taken for long periods of time?
Yeah, great question, and that's why it's always a balance. If we said today, and I hope the message doesn't go out saying, oh, we should treat everyone with MGUS and smoldering. I'm not advocating for that. I'm saying that there are some patients who would benefit from treatment, and actually it may be more harmful for them to stay without treatment because they will have more problems in the future. However, you're right, we need to have drugs that do not have bad toxicity, that will not damage their stem cells, and are not given for a very long duration of treatment. And that's why we're thinking of very short, active therapy. Think of it more like a surgical intervention. You go in, you remove it, and it's gone. You don't have to keep going on with treatment and a lot of toxicity.
Okay, fantastic. Do you have time for a couple more questions?
Absolutely.
Okay, fantastic. Let me do this first. Is anybody, Priya, that is online ready?
Yes, there's a question. Calling in from 503-727-5303. Please ask a question.
I didn't hear this question well. Sorry, can you say it again? Your line is not as clear.
Please ask your question. Caller calling in from 503-727-5303. Please ask your question. No, Gary, I think we have lost.
Okay.
Maybe we
a couple more questions. Yeah. A couple more questions, and then we'll, if we got the time, Priya, and then we'll go and we'll sum it all up. Okay, a 29-year-old male from India detected with MM in August of 2013, 15 chemos done, auto stem cell transplant completed in 2014, now considering maintenance drug thalidomide, but I am also planning to start a family sometime soon. So the question is, do I go to the thalidomide and stop it for a while before planning for a family, or go to bortezomib but risk losing out on the drug in case of a relapse?
Yeah, so it's a good question. The practice in India might be very different than the practice in the U.S., and we do not use thalidomide for maintenance here anymore. We use lenalidomide, which is a cousin of thalidomide and has the same problems, of course. Again, it depends on the patient and the discussion with the physician. I would say you can do sperm collection and then go on lenalidomide or on bortezomib or any of those other drugs. That could be one option. Or you can take a small time period off from maintenance therapy to, of course, have your family and then go back on maintenance therapy. But these are things to be discussed on a personal level with your physician.
I had heard that he had an auto stem cell transplant plus 15 chemos. Doesn't that
affect? Yeah,
have an
it
impact
could.
On? Yeah.
Yeah, absolutely.
Make a person sterile or no?
Not necessarily. It depends. It depends on the patient. And again, this is where sperm collections are very important.
But before the stem cell transplant, or
correct. Yeah.
Or you should be talking about this before treatment if you're a younger person, a younger patient.
Correct.
Okay. And one last one. It's hi, doctor. Do you think that treating someone with smoldering myeloma might bring a cure? And is there any research going on to investigate this?
So I think, yes. I think we just need to find the right combination and the right time. But if we're going to cure myeloma, I think earlier treatment will probably be the place to go. We're doing clinical trials to ask that question. So until then, we do not have the answer, but this is the hope.
Okay, and I think with people like yourself working on these questions, and Pat was correct. I was enamored at what you were saying, but but it was because, to me, what you were saying is that you have the potential in your sights to cure this thing and to find it before it ever reaches the crab state or ever reaches a multiple myeloma. So for me, it's so exciting, this possibility, that I just could not keep away from our listeners.
Well, thank you so much.
So with that, Priya, could you bring it?
Thank you,
bring
Gary.
it home?
Thank you very much. Yeah, sure. Thank you, Gary. Dr. Ghobrial, it has been amazing listening to you. You've shared so much information with our listeners today. Thank you for being with us. Matt, Pat, and Cindy, thanks a lot. Listeners, please join us again for our next myeloma episode, where we will be discussing transplant with Dr. William Bensinger on March 26th at 5 p.m. Eastern Time. The link for today's broadcast I will be shared with all our participants and will be available on Cure Talks website by tomorrow. Please visit curetalks.com to register for our upcoming shows. And thank you so very much.
Thank you very much.
Thank you very much.